half of the population, that is over 7 billion people. So we're talking about half of that being 3.5 billion people not having access to healthcare. So what is the status and how can we be able to address some of these loopholes in the medical system? Well, our guest tonight, we have Dr.Got Akuno, who is a medical practitioner, as well as Dr.Rudi Eggers, who is from the World Health Organization. He's a representative from WHO, and they will be putting into perspective some of these things. Welcome, gentlemen, to our studios.
Thank you.
Let's begin with, what is the level of access to healthcare on a global platform before we get to the Kenyan scenario?
So as you mentioned, many people don't have access to healthcare. It's not quite as bad as you illustrate. People do have access to healthcare, but the problem is they have to pay for it. They have to pay out-of-pocket expenditure. In some cases, that causes financial hardship, that causes the family not to have enough food to eat or livelihood. So it's a matter of both of the provision of healthcare services, but also the payment and the ability to pay for these services.
On a global scale, what would you say is the situation?
I think your figures are quite correct. So if you take into consideration the out-of-pocket expenditure, that is the approximate figure, yes.
In the Kenyan scenario, Dr. Akuno, what would you say is the situation in terms of access?
Access is a factor of several issues. Access will, of course, be determined by, first, is availability. Is it available for you to access it? Two, once you've considered the issue of availability, then the issue of cost will determine access, because the service can be there, but you can't afford it, so it becomes inaccessible as a result of cost. Then another thing that we must also factor in is acceptability. Is what is there available socially acceptable to our people?
What do you mean by that?
By that I mean, see, healthcare, unlike other goods and services, is affected by a lot of social determinants. One of them is education. So I know earlier on in my career, I've worked in places where culture alone affects how people will consume health services that are actually there.
The belief in witchcraft as opposed to...
the belief in witchcraft. I've worked in places where a mother would undergo a cesarean section first time, would be clearly advised that the reasons why you had a cesarean section first time are irreversible reasons. So next time you conceive, please come to hospital early. We are planning an elective cesarean section. But during that first delivery, some of them get abandoned in hospitals. Their husbands take off. They are left there. Do you think she'll come next time? She won't. So they are what I call the social determinants of healthcare itself and health-seeking behavior. So those are major issues when it comes to access in a country like ours. Yes.
Okay, and just looking at, our situation as a country, the fact that we're devolving healthcare system, do you think this is helping in addressing some of those issues?
Devolution per se, the overriding theme of devolution was, first of all, to make communities responsible for certain social services that actually directly affects them. And healthcare is one of those things that I feel directly affects the lives of our people. And devolution per se, to me, has never been a problem. The problem has been the how. So that is where I think the country lost track. And an honest debate at this level, because we've now been with it for about 4 years. It is now time. The jury is now out there. Yes.
We'll be talking about whether it's viable or not. But before we get to that, let's look at, we're talking about, if we talk about universal health care under the SDGs, we are saying at least 1 billion people should have access by 2023. How attainable is that, based on, the factors?
It's a very ambitious goal. So it does require especially political commitment. And actually here in Kenya, we are quite fortunate in the fact that His Excellency the President has declared it as one of the 4 pillars of the government's delivery. So the political commitment actually makes things easier. If the government stand behind universal health coverage, that makes a big difference. But of course, you have to have the funding for it to be able to serve the entire population, everybody, everywhere. You actually need to fund that. You need to pay the healthcare providers. So that needs additional resources. Those resources have to come from government, from taxes, from the population. So it is quite an ambitious thing. It is doable, however. Many countries have done it. Also, countries in similar circumstances as Kenya. So it has to be incrementally increased, and then it can be done.
And then what about the question of duplication? Because besides just the government, we also have, NGOs. We have, we've seen churches, religious organizations also trying to do the same. Is there a collaborative effort to ensure that we move together?
We have to. I mean, that's really critical. So part of the design of the universal health coverage has to be a decrease of fragmentation. So currently, as you say, there's a lot of fragmentation, different services being provided at different cost, at different quality, in different places. And I think the design of the universal health coverage has to be such that there's uniformity in cost, in quality, in availability.
What about the question, you had mentioned earlier, the out-of-pocket expenses? How do we address that? How do we factor it in this entire thing?
Well, the Ministry of Health is in the process of designing that system now. But at the basis is that there should be an essential health care package that should be subsidized by government, that should be free for all. So those essential services should be available. And then on top of that, there should be services that can be covered by insurance, by vulnerable groups can be specifically funded, like you currently have the Linda Mama program. So those kind of things can be put on top of it. But at the basis, there should be an essential healthcare package that is subsidized by government.
Is it possible for government to be able to meet, some of these costs?
Yes, it is possible.
Okay.
I believe it is possible. I've just been looking at the propositions made on the President's Big Four agenda, specifically universal healthcare. And I think now we are beginning to look at some statistical markers that should be able to point to us exactly where we need to go. Now, looking at it, by 2017, our National Hospital Insurance Fund membership was about 36% of the country. If you look at our population, it's about 46 million. So we are talking about around 16.5 million people being members of the fund. I think those is both principal members and beneficiaries. But you see that one already locks out another 64%.
Yes.
So like 2/3 of the population is being left behind. Also looking at what the president's technical team is synthesizing, they are projecting that the country's population will grow by about 1 million a year over the planning period, which is 5 years. And they are projecting that by 2022, we need to have 100% coverage, which is, it's ambitious, but it is achievable, because I looked at what the financing proposals are. They are financing proposals that I know are feasible. And I
Do
know,
they cater for, the out-of-pocket expenses?
Now, what we need to look at critically is how do our people consume formal health services? Formal, by formal I mean the usual hospital system. The fact of the matter is about 65 to 70% of our people, they either go to dispensaries, health centers, or sub-county hospitals, or what used to be district hospitals. Another maybe 30%, they somehow end up at higher levels. Now, what universal healthcare, and my colleague has hinted to it, we must operate on one platform. We must minimize fragmentation as much as possible. So that is why I keep saying in the fora where we're discussing this, that the biggest task that the President's implementation team has is to settle on what we call as a service level package. What is the expectation of a Kenyan who visits a dispensary level facility, whether it is private, public, or faith-based? What is the minimum expectation for a Kenyan who visits a health center, whether it is public, private, or faith-based? What is the expectation of a Kenyan who visits a sub-county hospital or a district hospital, whether it is public, private, or faith-based? Because, why is this important? It's important because once you standardize the minimum expectation, first, it makes your staffing easier because it determines the kind of competencies you need at what level. It makes your costing of human resource straightforward. 2, it makes your costing of equipment and supplies straightforward. More importantly, which we are going to, is if 70% of our people are consuming healthcare at dispensary, health center, and sub-county hospitals, then it goes without saying that those services should be free. I believe that those services should be free. They should be free because we are in a country where about 50% of our people cannot afford the market price for health. So
but is it possible to standardize? Because, I mean, it's a free market economy.
No. There are things that can be standardized. I believe there is a licensing mechanism for these hospitals. For whether they are private or public, there is someone that inspects them and licenses them. It is that body that will come up with a generic standard for what level of care. That body.
All right, Dr. Eggers, I'd like to hear your thoughts on what he's saying.
Well, I think I could add 2 things. You mentioned it right at the beginning. So in the question on the resources, one should also look at the inefficiencies. So there are a lot of inefficiencies in the system that by making the system more efficient will actually reduce cost. So that should be one of the key components of the design of the system, is by defragmenting the system is to reduce the inefficiencies. You mentioned earlier that patients go directly to tertiary hospitals. Now, services at a tertiary hospital are of essence much more expensive.
Yes.
You've got specialists, you've got much more expensive equipment. So a person accessing this for a minor illness actually is wasting money, if you'd like. So we need to design the system so that the referral properly works, so that the person that does require referral can actually get it without problems, but that most of the other services are provided at the local facilities. The second thing I'd just like to highlight is you also mentioned the issue around preventive versus curative systems. So if we do our preventive and promotive healthcare properly, we can expect that some of the diseases will actually decline. So you mentioned immunization. Of course, you would expect measles and those kind of diseases to be reduced if you do immunization properly.
But are we putting enough resources towards preventive?
I think the design of the system should be such that we do that. There's some talk of putting incentives into the system to make sure that the counties actually design a mechanism that they don't leave out the preventive and the promotive sector. This includes things like road safety or alcohol abuse or obesity, those kind of things. So it goes way beyond the classical treatment of illness.
So more resources perhaps should be put towards preventive as opposed to curative. But I know
Absolutely.
you're going to...
It has to be incentivized, so the counties should be driven in that direction, because it's so much more effective.
All right, let's talk about staffing in itself. We've seen countries engaging in what we call medical tourism. Countries specializing in certain cures for certain diseases, treatment, and a majority of Kenyans will always tell you that they're going abroad to get treatment. What does it tell us about our universal health care?
Let me approach it this way. The last point I made was some level of standardization and making services up to the level of sub-county hospitals free. And I mean it should be free. because of two reasons. Number one of the biggest problems we are having in this country today is indisciplined referral. The referral system has collapsed and it is indisciplined. What does that lead to? It is leading to congestion in Kenyatta for things that should be treated at Dagoretti Health Center.
But do you expect a doctor in Kenyatta to turn away a patient when they come in?
Look, we cannot turn them away now. But what we should put, the inbuilt system we should put in our universal healthcare should make it punitive for you to go there. How do we make it punitive? If we make it free at health center, at sub-county hospitals and at dispensaries, then register every household. Every household must have their primary care facility where they are registered and attached, where if you visit that place, the fund will pay. But if you bypass it, you will be penalized and you will pay out of pocket. Because we must make sure that whatever resources that we have that are little, we use them in a reasonable manner. Now, off to your question on going abroad.
Medical tourism.
Medical tourism.
Call it that.
Luckily, a few occasions I've had the privilege of sitting in fora where we are trying to assess patients who have been referred abroad for certain treatments. I am specializing in head and neck surgery. So basically, some of them are sent to us in what we call the tumor boards in Kenyatta for us to review them. The truth of the matter is, some of these referrals are not, they are being pushed by ulterior motives. So, if it is the public funding it, then the public has to put their feet down and say that we will not condone unnecessary referrals abroad.
So you're talking about some level of dishonesty within
I would say some of it, like, you see, when such patients appear before you as a panel to deliver an opinion, you go through everything and you feel that service is available within the country. Of course, you have to write back to the Director of Medical Services and honestly say, these are the management options. They are available within the country. So it is the Director of Medical Services to decide whether he will approve for them to go or not. I hope the fund will have a provision that once such a panel makes that decision, if you are going to go, then you go at your own cost, not at the cost of the taxpayer.
All right. As WHO, what is your take on medical tourism?
On both the questions that you asked now, both on the medical tourism but also on the referral, at the basis of that is really the quality of the services. So for both those, universal health coverage has as one of its key components making sure that the quality of services is good. So if you have actually health facilities that are offering stellar quality services, you actually will find that the patients would prefer going there instead of going to Kenyatta because they're getting the services that they need. Similarly, I think in terms of medical tourism, I think Kenya has moved dramatically, has moved far from where it was in terms of the quality of services that are available now to what they were 10 years ago. So I think we are on our way to actually improving the services, the availability, but also the quality of those services. And for both those, once we actually reach a level of quality of services, I think you will find that both those problems decline as problems.
What about the staffing levels? Because there's always a perception that medicine pays better outside Kenya as opposed to here, especially when you keep seeing the doctors going on strike every other time. You may tend to believe that.
Well, I mean, that the doctors go on strike, that happens in many countries, but of course it is that actually limits the ability to deliver the services. We know our immunization coverage has dropped dramatically.
Yeah, by 10% in the past 5 years.
That was in the period that the health workers were on strike. But clearly, it's the quality of the health workers that make the quality of the service. So that's the key component. So our training must be of high quality, but also the supervision, the incentive to the health workers has to be there. And I think for the patient, it is really important, as you pointed out, that they understand that the referral system is working. If I actually do need to be referred, there will be a way that I can be referred. If that assurance can be given and it can be shown, I think patients would become more comfortable with the level that they are being treated at.
Why are your colleagues choosing to work abroad as opposed to Kenya?
Now, this issue of strike and everything, I think, let me take it together. There is a way in which I think this country has been tried. People have wired this country to work. And it is what I call a way of dishonesty or apartheid. I'm not afraid of using those terms. Some of the agitations are informed from a feeling of being ignored or some kind of opaqueness. And I must admit, for example, let's look at simple things. A health worker today working in a certain county government. Certain county government has deliberately decided, you see the insurance cover for what I call the civil servants. When they were all under the national government, everyone was enrolled to what we call the civil servants medical scheme. Now, you suddenly devolve them, and a certain county intransigently pulls out those people from the civil servants medical scheme. It has pulled them from the medical scheme. It has withdrawn their medical allowance. Yet, you look at the people who are making policy decisions about you. We look at what I call the state officers. Luckily, thanks to SRC, these things can no longer be hidden anymore. You look at the SRC Gazette notice done sometime in April last year. It gave the benefits that these state officers who are deciding about you, what they are getting. And almost all of them, first, they have
Our time is running out, so I want you to conclude.
Private medical covers of up to about 10 million shillings. The same person pulling you out of the basic civil servants medical cover, he himself and his family has a private medical insurance to the tune of 10 million shillings. What will stop you from revolting?
So it is you're sitting basically and comparing.
We can no longer do apartheid in the health sector anymore.
So it is harmonization of salaries that you want.
What is good for my president should also be good for my mother in the village.
Okay, so 10 seconds, just look into the camera.
If it is the health center that is good for my mother,
yes,
it should also be good for my president. And if it is not good enough, then he should pay for that other one from his pocket, not from public taxes.
Okay, Dr. Eggers, I'll just give you 10 seconds to speak to the Kenyan people regarding the status of universal healthcare and what we can do to change the situation that we are in currently.
So I think Kenya is in a very unique situation. They've got the political will. They've got the political will really to put universal health coverage on the table for the next 5 years. I think that is a huge opportunity. It is the ability to leapfrog the health of a nation and to make everybody much more healthy, more productive, and hopefully more happy.
All right. Thank you, gentlemen. Unfortunately, our time is up. I'm sure Dr. Akuno will have you back to have a discussion about the money. Well, this is where we put a cap on your health segment. Today, talking to Dr.Got Akuno, who is a medical practitioner, as well as Dr. Rudi Eggers, who is from the World Health Organization, putting into perspective how exactly can we be able to achieve universal health care. That, of course, is formed under the SDGs. And the fundamental thing that is coming out is this need to put in more resources and, of course, focus on preventive health care. This is where we put a cap, but of course business news is coming up shortly, so stay tuned.